but it would be good to show it in full screen probably.
Can I go ahead and start?
Yeah, go ahead.
Okay, you need to give me host.
I need to give you. Okay. So, yeah, good afternoon, colleagues, friends, and everyone who has joined. I'd like to take this opportunity to welcome all of you to the webinar we are having for the College of Health Sciences on COVID-19. Just to get an update from our esteemed colleagues in terms of where things are at. It's been a while since we've had one of these conversations. We're going to try and keep it neat and tight. The plan for today is that we will have one of our panelists do a brief presentation just to share an update, and then we will get into a discussion. As much as possible, I will try to screen through the questions that you have for the panelists. If you can make sure that you enter them in the Q&A, and then I will go through that and synthesize them and raise them with the panelists. That will be most appreciated. I'm sure that our panelists need no introduction. We've got Richard Lessos, our infectious disease epidemiologist. We've got Nukanya Msomi, our clinical virologists, and both of them, you know them really well. And I would really appreciate also if you can make sure that you take the time to engage in the discussion. So without wasting further time, let me invite Richard to kick us off with a few slides, and then we will get into a discussion right away. Thank you so much, Richard. Over to you.
Thank you very much. And as you say, I think when we start to think about what's next and what's coming and how we need to modify our response, the first step is we just need to reflect together on where we've been and where we are currently. And so I just have a few slides really just to set the scene for the discussion and just to remind ourselves of what we've all lived through in the past 2 years. And so here I'm just going to show these few slides and just remind us all what we've been through. So here I'm showing you, first of all, just the simple epidemic curve, just reminding us of these 4 waves of infection that we've been through and that we all remember. And what we're seeing in the blue is the cases, the weekly cases, and then in the black is the number of deaths. And what we see clearly is how well-defined these waves have been and how periodic, every 6 months or so, we've had one of these waves of infection. And I think what you can see is quite striking, and what we've all realized over the past few months is one of the good things is that in this last wave of infection with the Omicron variant, despite a lot of cases and a very rapid rise in cases, there was something different about what we saw with the severity of disease and the number of deaths in that wave. And so what you see clearly here is the difference between the second wave particularly and the third wave with a high number of deaths. And then you see this lower number of deaths. Of course, that number is not zero. And unfortunately, we still saw many deaths in the Omicron wave. But relative to the second and third wave, it was considerably lower. And we'll explain why we think that is in a second. Here is a nice map that we often show because it's the best map we have that shows the kind of spatial pattern of infection across South Africa. And this is a map produced by the NICD every week. And it's showing the test positivity rate. So it's not showing the number of cases, but it's showing of all the PCR and antigen tests done in each sub-district, what proportion of those are positive in each week. And you don't need to look at the detail, but here essentially the darker green is the lowest test positivity, and means that somewhere around 1 to 2% or so of your tests are coming up positive. And then as you go to the lighter green, the yellow and the orange, it's a higher test positivity. And really, I'm just showing you this because the green that we see, particularly in our province here in KZN and also Eastern Cape, this means that we're getting fewer positive tests of all the people that are coming forward for testing. Few of them are testing positive for COVID. And this gives us an indication that although there's still virus around and the virus is still circulating in our communities, it's back at a relatively low level again as we've come through the worst of this fourth wave. Now, here's just a different way of showing the epidemic curve, and this is just to highlight the importance that the variants of this virus have demonstrated over time. So here we're showing you again the cases over time and these well-defined waves of infection, and then the color is showing you what variant caused the infections predominantly during that wave. And what we've seen very clearly in South Africa is that these waves have been driven by the emergence of these different variants. So the second wave we saw in November, December 2020 was driven by what would become called the beta variant. And then we saw the Delta variant be introduced to South Africa and cause this third wave of infections. And then, of course, most recently, we've seen this Omicron variant emerge and cause this very rapid but relatively short wave of infections. And one thing that you notice now, and you've probably seen over the past few weeks, is that there's a little bit of a kind of prolonged tail of this Omicron wave. So we haven't yet got down to the very low levels of infection that we saw in October or so after the Delta wave. And part of the reason for that, if I show you in the next slide, is that we've seen these different, what we call sublineages of Omicron. So this is all Omicron infections.
Just 1 second. Pause for a second. I just want to the students that are here to say that you are most welcome to be in the meeting, but I'd like to request that you kind of make sure that you behave and the comments you make are all respectful. I would really appreciate that. And if you're not really happy to be here, you're welcome to leave. so that the people that are here, we know that they're interested in the discussion. And if you're here, pay attention. I don't want you to feel like you're forced to be here, and would like to make sure that we screen the comments to be able to engage properly in the time that we have. Thank you so much. Otherwise, you're all most welcome. Richard, continue. Thank you.
So one of the reasons for this kind of prolonged tail of the Omicron wave is that we've seen these different forms of Omicron. So you'll be familiar that when we describe a variant like Omicron, there are often kind of slightly different versions of that variant. And we've seen that here, that most of the infections of Omicron wave were caused by what we call BA.1. But then towards since the kind of end of December, beginning of January, we've seen more of the infections actually being from what's called BA.2. And that may have contributed to some of the kind of infections we saw in young people, particularly when the schools restarted. And that will have contributed to this kind of extension of the Omicron wave, and why we haven't kind of got right down to very low numbers of infections in the last few weeks. But based on what we understand about Omicron and these different lineages, we don't think that the BA.2 is likely to cause a big resurgence of infections over the next few weeks. We think that it's clearly causing most of the infections now, but we think that the immunity that has been built up in the population from the BA.1 infections will protect many people from getting infected with BA.2. And we can discuss more of that because it gets a little bit complicated to think about. One of the important things always here is to understand that what we see from the reported numbers is not necessarily the true reflection of the impact of this virus and this pandemic. And one of the great strengths in South Africa is the surveillance that we had prior to this pandemic. So a surveillance program that's been long-standing, that just looks at the overall mortality in the country and surveys the weekly deaths. And this has enabled us to see what the true impact of the pandemic in South Africa is. And so here you're seeing this graph that they update on a weekly basis. And here in the orange, you see what the predicted number of deaths would be based on the few years before the pandemic, based on the average number of deaths over the few years prior to the pandemic. And so again, what you're seeing is these deaths occurring in these 4 waves of infection, but you see that the total number of additional deaths to what would be expected is now around 300,000. And so the key thing to note there is that that's roughly about 3 times what the reported deaths are. And it highlights that the underreporting of cases and of deaths leads to a big underestimate of the true impact of the pandemic. And the other thing that's always important to note is that the vast majority of these deaths are still in elderly people. 3/4 of these deaths have occurred in people over the age of 60 years. So we know from that we've had a very significant epidemic in South Africa with these 4 waves of infection. And we know now, if we look at all the data that we've accumulated over time, and if we look at what we call serosurvey data or serological studies, where they test people whether they have antibodies to this virus, we know that most of us if not all of us, have been exposed to this virus by now, at least once, and many people probably twice or 3 times. And here I'm just showing you results from one particular survey, which is a nice survey that can look across multiple provinces, where they take the blood from blood donors, so from the National Blood Service, and they just test for antibodies to the virus. And here I'm showing you that prior to the Omicron wave, so in early November, across all the provinces, somewhere between 70 to 80% of blood donors had antibodies to this virus. So we know that even prior to Omicron, most people had been exposed to the virus. And if we now put on top of that all the people that were infected during the Omicron wave, that's why I say that most, if not all of us, have been exposed to this virus at least once. Where are we with vaccination? Well, here I'm showing you a graph that shows you what is the coverage of vaccination in the different age groups. And so here, I'm showing you in the 60 plus years, this is the proportion that are fully vaccinated. And by fully vaccinated here, I'm just meaning the primary series of vaccines. So that's the 2 doses of Pfizer or the 1 dose of the Janssen J&J vaccine. And you can see about 60% now are fully vaccinated, and another 5 to 10% are partially vaccinated. So that means they've had the 1 dose of the Pfizer. And then you see, as we go down the age groups, this proportion obviously gets lower. So the coverage is lower in the younger age groups. But one of the key things is that this means there's still a significant number of people over the age of 50 who are the people at highest risk of getting very sick and of dying from this infection. There's still a significant number that haven't yet received their first vaccine dose. And we now know, and I'm sure we'll come on to discuss, the importance of the booster dose also to enhance the protection that we have against particularly Omicron. And we know that the uptake of the booster dose is actually quite disappointing. So fewer than 1 million people who've received their primary vaccination series have taken up the offer of the booster dose. And this is something that we need to address now altogether to try and improve the uptake of the booster dose, particularly amongst the people at highest risk of getting very sick. And I think that no talk about COVID is complete without just remembering the challenges that we've had in dealing with this as a global pandemic. And here we're just showing you this problem of the inequitable distribution of vaccines across the world. That while we've obviously now had good access to vaccines in South Africa, there's still challenges across the continent, and we're still far behind the rest of the world. Here you're seeing that in many parts of the world, they're now reaching levels where they're giving 4th doses to their general population. So they've got most of the population who've received already 3 doses and are now receiving another booster dose. Whereas you see throughout most of Africa, it's still way below half of the population who've received any vaccine dose. So we still have these huge challenges, and this means that depending on what the future does hold in terms of new variants and new waves of infection, we still have one continent that's been left behind and that is still vulnerable if we do see more serious effects of this virus going forward. So I will stop there and hope that that just sets the scene for some of the questions and the discussion that we'll move on to.
Thank you so much, Richard, for those opening remarks. May I also invite Dr. Kanyim-Somi to also just make your opening remarks. You can either comment on some of the things that Richard has stated or add any comments you'd like to add. I should state that Dr. Kanyim-Somi has also recently obtained her Doctor of Philosophy. So we're very proud and congratulations to you. I don't know how you did it during the pandemic, but somehow you pulled through. So we're very proud and congratulations. So please, your remarks.
Thank you very much, Prof. Moshabela, and good afternoon to everybody that has joined us on this webinar. It is nice indeed to come and chat to everybody within the university community and anybody who's outside listening in on this discussion, which I think is very relevant. Just picking up on what Dr. Lessels has touched on, what clearly comes across from what we've gone through in the past 2 years of the epidemic or the pandemic globally is that typically in South Africa, it's been driven, each wave is driven specifically by a specific variant. And what in the spirit of the topic for today, which is what next, perhaps what should come into our discussion or how we should try and which questions we should try to answer would include things like how do we stay ahead of these variants because they seem to feature very prominently with each passing wave. How do we minimize the emergence of these variants, if at all? And how do we minimize the spread of infections? So help each other with tips on how do we essentially coexist with the virus or with the epidemic so that in the long term we'll minimize the number of deaths and obviously minimize the number of hospitalizations or any long-term effects that come with this infection. So I'm quite keen to engage on this and discuss what next. Thanks.
Thank you. Thank you so much. So Richard, let me come back to you. You have mentioned the issue of, so firstly, are we now out of the fourth wave? Are we out of the fourth wave? Are we safe? Can we relax? Can we begin to drop our masks and just carry on with our lives?
So I don't know. Technically, I don't know if we're fully out of the fourth wave across national. I don't follow the kind of always the technical definitions of kind of when we meet the various thresholds and things. I mean, I think we're clearly at a level of much lower level transmission again. But I think we all know just in our networks and things, we're still seeing colleagues, friends, family members test positive now and again. So the virus is still there. I think what we've realized with this last wave is that we are in a different phase of the pandemic now, and we do need to think now about the kind of longer term public health strategy and the public health response. I think we've seen that as these variants have emerged that have become more and more transmissible, it's become even more challenging for us in South Africa to stop or to slow the spread of this virus when it takes off. And I think that we've realized that actually the priority is very much the protection of people that are at highest risk of getting very sick and of dying. And that's where the focus must be. But that doesn't necessarily mean that we give up on everything else, that we give up on trying to stop infections, but it means that we have to kind of focus our strategy on what we know works and is effective.
Yeah, I mean, we will need to make sure that the messages around this are clear, because at the moment we get a lot of different mixed messages, and I think that for those who are in the inner circles of these discussions, you sit in the MAC. Which one? For vaccination? So some of you have sort of inner information and you are comfortable in the discussions that are being had. But if you now look at it from the perspective of the general public or the general university community, a lot of people don't have access to that information. So we miss out on the nuances of the debates and as they change, because it's almost like the story changes after every wave, for example, or during every wave. And so we miss out on the nuances, and we have to think, for example, about how to make sure that those messages are crafted in a way that is clear and in some ways consistent, so that it doesn't create confusion. But let me hear what can you think about where we are at. Can we hang our t-shirts? Can we hang our boots? What do you think?
Certainly not. I do not think we can afford to do that yet. Specifically because, as Richard has said earlier, we still have ongoing, albeit low-level transmission, which means the likelihood of a resurgence occurring is always there. We also have learned what has worked, and we know what works. And as long as the threat persists, I do not think we can afford to let go of the things that have been proven to work. The other advantage we have is, obviously, we are in a global village, and we're learning from experiences from countries that are a little bit ahead of us in either the pandemic evolution or the vaccination programs that they have run. So we do have the benefit of learning from what others have put in place, and also learn what not to do from countries that have kind of let their guard down too early. And we've seen the massive resurgence in those countries, for example, that have gone as far as removing masks mandates. We have seen, so now we know that no one level of protection is sufficient. So I would definitely encourage that we use every armament in our arsenal to fight until we are out in the clear.
Okay, so we could need to continue to follow the precautions, put on those masks. But now we know a lot of people don't want to put on the masks as well. And I feel bad talking to you not wearing a mask already, even though I'm on Zoom. But a lot of people don't want to wear masks, and people now just go into crowded spaces. People want normality. How do we communicate then the nuance of the message around continuing to follow precautions in an environment where we've got low-level transmission to a point where many people are spreading the message that COVID is gone, in an environment where, in a way, we've got high levels of immunity from both vaccines and infections, especially if you combine those two. And also in an environment where policy-wise, people are almost seeming like they are now giving up, they're letting go. And it's almost like, let's just carry on. So how do we galvanize the message around what you are saying in terms of the precautions we need to continue to take, learning from the Hong Kongs of this world, where now they're having their own surges and so forth. So how do we do that, Richard?
Well, I think we rationalize the kind of measures that we're taking, and we bring them into a more kind of common sense approach. And like Kanye said, based on what we know is most likely to be effective. So if we take the mask use, I mean, we know that's one thing that's been very consistent here in terms of the policy. And of course, there's been differences in adherence to that over time. But I mean, generally, that's been good. But I think now, I mean, it makes no sense that we are still wearing masks in outdoor spaces. And I think that we can rationalize some of these things to focus on the kind of highest risk places or kind of exposures where we would still encourage people to wear masks. But we can get rid of some of the places where it's really not necessary and not likely to contribute at all to slowing transmission. So I think that kind of rationalizing of things would help to bring it more in line to where we are now, as opposed to where we were a year ago or 2 years ago.
Yeah. Kanye, your thoughts?
I agree with what Richard is saying. Maybe I'll just add on, perhaps our continuous messaging needs to go back to basics in trying to take everybody along on understanding the fundamentals of how this particular virus spreads and what type of environments favor the transmission from one person to the other, and what type of environments are less risky, like Richard has mentioned, that outdoors is not as highly risky as indoors, and make people aware of where they are highest at risk, and so that they can own their own prevention and take precautions appropriately, and obviously precautions that are sustainable, because like Richard says, if we're wearing masks everywhere all the time, then the reality of fatigue filters in. So maybe if we can have measured responses according to the risks and clearly communicating to everybody where the highest risk of exposure is, and making sure that everybody understands.
Okay. So let's get a little bit into the immunity issue. A number of questions that are coming through having to do with the fact that, of course, it looks like the policy position and the way we see what we need to do and the messages we need to send out depends on where we are currently. And that situation may change. So, for example, we've got a situation where we might have waning antibodies, right? Can you comment on that in terms of right now our vaccination rate is low? People are not necessarily taking boosters. Well, let me say our vaccination rate is good on average, but then for younger people, it's lower. Even though, of course, for those who are at risk, it's a little bit high, around 60-70%. So that is good. But we also know that generally, at an average of less than 45%, less than 50%, we are still low compared to countries that we are looking at in terms of policies. And now we are relying on immunity from infection, but we also know that the antibodies would wane. So the first question is just what is the meaning of that? How should we be looking at this, both at a collective level, population level, and at an individual level? And the second question has to do with this question of T-cell immunity. The fact that, yes, a person can have an infection and antibodies might wane, or they can get vaccinated with 1 dose or 2 doses, but there's also a message that says your T-cell immunity can persist. And here then the significance is, just for everyone to be on the same page, is that the antibodies would generally protect you from that. It's like your first line for all intents and purposes, your first line of defense, and it will protect you from exposure to infection and so forth. But the T cells will allow you you will get infected, but they will protect you from severe disease and probably even death. And we've been punting a policy that says that we really want to protect people from severe disease and death. So the first question is, what is the meaning for everyone of these waning antibodies, and at an individual level and at a general population level? And also then, what is the significance of the T-cell immunity? Can we count on it? So one of the questions was, can we rely on one dose of the vaccine? Why is that not enough? Can we rely on the primary series only, if that generates adequate T-cell immunity? Can we rely on having recovered, if that generates T-cell immunity? So let me start with you, Khanyi, and then I'll come back to Richard.
Okay, thank you. So on the issue of waning immunity, whether it's waning immunity from natural infection or vaccination, also being mindful that antibody immunity wanes, whether it's naturally acquired or whether it's vaccine acquired. At an individual level, antibodies will obviously prevent from acquisition of infection to a certain level, but would also reduce the amount of reduce the risk of transmission. But what the main focus is on the severity of disease, which is what the T-cell immunity confers, and the T-cells that you've mentioned. We do want to have both, because you want to prevent infection and from occurring, but you also want to prevent disease. Relying on only antibodies, we must be mindful of the fact that the risk of going through the infection is too much of a risk to accept, because different people will have different outcomes. You may be unfortunate in that you fall within the group that may have severe outcomes, and the fact that you also don't exist as an island, you live with other people. You may live in a household or in congregate settings like in residences as such, where a lot of people become exposed from one case. So it's very important to have all levels of infection, of protection, those that are conferred by antibodies. And if you've not been infected, a vaccine would definitely be the best way of acquiring those. But being mindful that antibodies wane over time, and if you get vaccinated, then the T-cell immune response may persist for long, and then at an individual level protect you from having a disease and the possible severe outcomes, which we do not always know what triggers one person from having a very severe outcomes, even when they are relatively young.
Yeah. Thank you. Richard, your thoughts?
Yeah, I mean, I agree. I mean, I think I think we've done quite a bad job collectively of explaining immunity from the beginning, and explaining this issue of waning antibodies and things. And that's partly because people like you and me don't understand immunology very well, or maybe I speak just for myself, but
I agree.
I mean, I've learned a lot about immunology through this pandemic, but I mean the basic, and we've never seen this kind of attention where in the media every day there's a story about a study that shows waning antibody levels and things. I mean, we've never had that level of attention to immunology. And the basic fact is that, I mean, your body produces antibodies in response to an infection or a vaccine, but it doesn't continue to churn out these same antibodies time over time, because if you're not exposed to that threat, your immune system is an amazing thing. It doesn't waste resources. So it doesn't just keep churning out antibodies against something that is not seen as a threat. Yeah. But it has that memory, and it stores that memory of that threat, and it's able to respond again if you're exposed to it. And so that kind of understanding of what these antibody levels mean and how they change is quite important, because the reason we hear so much about antibodies is just because these are the easiest things to measure. And so there's lots of studies where we look at antibodies. But when we think about the protection from our immune system, it's much more complicated, it's much more multi-layered, and there's that memory that is critical. And I think that what we have a pretty good understanding of now is that to get the kind of best level of protection, we probably need 3 kind of exposures to either the virus or the vaccine. Now, of course, we know that preferably that's to the vaccine. Preferably that would be 3 shots.
You don't want to expose people to infections.
Yeah. Exactly. But we know that many people have been. But the critical thing is if somebody has had infection, it's that you still really need the vaccine, and probably at least 2 doses of the vaccine, to really enhance that immunity and give you that long-lasting immunity that we hope will be more long-lasting, will be more durable, that you've got that level of memory set up that will allow you to respond should you face the virus in the future.
Sure.
And clearly the critical thing there is that we've seen that layer of protection against infection has become less effective over time as the virus has evolved. And we've seen these highly transmissible variants that can infect you so well that first layer of defense is too late even to kick in to stop the infection, but the immunity still can protect you from getting very sick with that infection.
So then, on the one hand, Richard, and this is where the message gets a little bit tricky. On the one hand, we are saying that the infection and the exposures, vaccines, infections, they generate immunity that can go to sleep, but it will have memory. It can be where you can wake up whenever it's exposed. So suppose we have the next wave of infections. We expect that those people that have developed immunity, their immune system can wake up and protect them. Then what is the case then for the boosters? Because if you're saying that having developed the immunity, then we will have the ability to have memory, then perhaps we don't need those boosters. And now I'm specifically playing the proverbial devil's advocate.
I mean, the reality is it is a booster. It will boost the protection that you have. It will enhance the protection that you will have. And it's doing that not just through boosting the antibodies, but also enhancing that memory response. And so it's strengthening the overall immune response. So that's really important because it's again getting away from this point that we're just boosting antibody responses for the sake of it, which is a very short-term thing. But actually the evidence shows us nicely that we're boosting all the different strands of that immunity. And I think clearly one of the problems has been from the beginning, we've been facing this challenge that of pitting vaccine-elicited immunity against infection-acquired immunity. And you notice I don't use this term natural immunity, because part of the challenge has been the misuse of that term to make it seem like a desirable thing, that it's better to acquire
Organic
natural immunity. And clearly that was taken up from the very beginning by the people that seek to discredit the vaccines and have that agenda. And we haven't been good enough at countering that from the beginning. But we do now have to be honest that many people have that immunity from infection because of how the pandemic has played out. And so we do have to be honest that is clearly contributing to the protection that they have. But we have to explain that it is still important to strengthen that immunity with the vaccines to give you the best protection as an individual, but also at a population level again to enhance the immunity across the protection across the population.
Yeah. Okay. So, Kanye, your thoughts on boosters? I mean, are they good? Should we promote them? I mean, a lot of people are wondering whether to go for boosters or not. A lot of people say to me that, look, I need to be honest, I was eager on the primary series. And when we say primary series, we're meaning the first set of vaccines according to the schedule, right? Your 1 dose of J&J and your 2 doses of Pfizer. That's your primary series. And then on top of that, we add a booster. So a lot of people say, look, they were keen on the primary series, but now on the booster, your thoughts, Kanye?
Maybe I'll just take it back to reminding everyone that the boosting thing did not just come with COVID vaccines. In our childhood vaccination series, I'm sure some of us who've gone through that journey would know that children will go for a vaccine at 6 weeks, 10 weeks, 14 weeks, 6 months, at different times. And what happens at those different times is the boosting occurs. And part of the boosting is training the immune system. Richard put it nicely when he says the immune system is not just producing antibodies continuously without being reminded. So this is where boosters come in, and that's where the significance is, in that it trains the immune system to obviously improve its response and also shorten the response time. The immune system, whenever there's a second exposure to a pathogen that it had previously seen, there is that precious time period when the antibodies or the T cells get built up. That time period is shortened when there was boosting that happened, what we call an anamnestic response. So there is definitely a case to be made for boosting and keeping the immune response strong and also well prepared to respond at as short a time as possible. And it's not new.
Okay, so we've covered an update. We've covered an update around cases. We've covered an update around deaths, the vaccines. We've covered the boosters. Now let's do a little bit of a marathon here in terms of covering some of the questions that people are asking. Richard, should we be giving 5 to 11 year age group vaccines? A lot of parents are concerned about this, sending kids to school and they cannot vaccinate. And you can see the uptake in those who are, 11 to 18. It looks good. It's 20%. It's not bad. And yes, it's a single dose for the most part, but it's not bad. What about 5 to 11 year olds? Keep it brief.
So in brief, I mean, as you know, it's kind of under discussion at the moment with the regulatory authority, SAPRA, and in the Vaccine MAC. I'm giving my own views here. I don't think that should be the priority for us. I mean, I think that, again, we would have to think what the objective of that is at a public health level. If you remember the graph I showed, the uptake in the 12 to 17-year-olds has been very poor. If you look at the coverage in that age group. And so we would expect it probably to be even less than that in the younger children. And so there's a question as to what are you going to achieve with that? And one of the things we haven't talked about enough with the vaccination program is the inequity in the vaccination program within South Africa, between more privileged groups and less privileged groups. And I would worry that opening it up overall to that group doesn't have a clear objective. As I say, that's a personal view, and it is something that is continually being discussed and looking at the evidence and what. Yeah.
But you also sit in the vaccine MAC, and in a way, you're giving us, some understanding of the thinking behind the scenes. I think the point you're making is that, yes, it's understandable that parents would worry for the 5 to 11-year-olds, but at the same time, we have a bigger problem that someone raised a question about rural areas, because we're showing the inequity between Africa and the rest of the world. So we can translate that even into the sort of local context to say even rural areas are less covered than urban areas, even though, we've seen some innovations in some predominantly rural provinces. So that's been good. But you are saying that trying to make sure that those that are underprivileged and are not covered with vaccines, that they get vaccines should be a primary goal. Those that, for example, have risk factors for severe disease should be the primary goal before we go for age groups where we get very small or marginal benefit and sometimes with low uptake. Okay, so that's the position for now. So Kanye, testing. One of the questions here is in terms of antigen and PCR. And I think I want to ask a general question about testing. Should we be testing for COVID-19? And if we're going to test rapid antigen tests when PCR, there's been a lot of discussions, even in the media, in the news around this issue, and perhaps add something about the benefit of testing when we are crossing boundaries as well. It's not a big issue, but if you can comment on that quickly.
Okay, so generally, whether we should be testing or not, I would not remove testing from our whole continuum of care. But on when the best value for testing is, maybe that's what we would need to apply. The different tests that you've mentioned, the antigen test versus the PCR test, would offer different levels of information depending on the test that we use. I would say there's definitely value in testing people who present with symptoms. So who are symptomatic. There is a value in also testing when there is a setting of an outbreak in a congregate setting. But the value decreases when it's used indiscriminately, like community-wide testing, especially at this level of the epidemic, where we know there's already a lot of exposure and the value is reduced. There is definitely less and less of value in testing for traveling, especially now that we have the vaccination as a prerequisite for traveling. So asymptomatic people returning from travel, I do not think there is great value in testing, considering that even our interventions on how we isolate based on whether you have symptoms or not have changed. So in that case, I would say we just need to look at who needs to get tested and what's the value you want to get from testing. So not testing indiscriminately, but very targeted based on patients who present with symptoms and a diagnosis needs to be made.
Okay, because that message then needs to be translated. I think the clinicians might understand it better, but that message would need to be translated to the general population so that they understand when the need to test arises. Can you quickly comment on the consistency between antigen and PCR testing? There's a concern in the comments that sometimes those results are discordant. What are your thoughts? I'll come to you, Richard.
Okay. So the difference in the two types of test is that they also have a difference in predicting whether it's positive or not, depending on where we are, what's the background infection rate. The antigen test tends to fare well and is more predictive when we have a high wave setting, so high prevalence settings. Whereas a PCR test does well across. And also an antigen test, because of a relatively lower sensitivity to the PCR test, would tend to detect only in people who are what I would term infectious or have, but there is a risk of false positives outside, high peak rates. So we need to be very careful on how we use the antigen test.
That's very helpful. Very helpful. Richard, your thoughts?
Yeah, no, I just wanted to, I wanted to agree with Kenya about that. I think we really need to rethink the testing strategy, and it's just as what are the goals of testing now as we move forward. And I think one of my problems with the kind of change in the guidelines that came out about isolation and quarantine and things was that was disconnected from thinking about testing. And I think it needed a much more comprehensive, coherent kind of revised strategy that encompassed testing as well as changes to the isolation and quarantine. Because in many ways, I think it's led to confusion again, that if people are testing and they're testing positive, but they're asymptomatic, then they don't need to isolate. And so it comes clearly to Kenny's point, what was the point of that test then? Because it's not leading to any action that's going to change an outcome. So I think we really do need to rethink as a whole public health strategy now what we need to do going forward, and I think that we can rationalize a lot.
Yeah. So two more questions that I think we're at time, but I would like us to address. One is about long COVID. If you can comment on long COVID. The second one that I would like to raise is about the fifth wave. Are we expecting a fifth wave? So Kanye, you can go first, either one of those two points, and then I'll come to you, Richard.
I'll leave Richard to open his crystal ball and tell us whether we're getting a fifth wave or not. I'll attempt to answer the question on long COVID. So long COVID, although there is no real strict definition, but it speaks to a persisting infection after the initial period of illness, not really persisting infection, but persisting symptoms, presenting in various ways. Some people report brain fog, chronic fatigue, some muscle pain, going for over 3 to 6 months after the initial infection occurred. And unfortunately, long COVID happens because infection was acquired naturally. And this is where vaccines come in that if protection is conferred through vaccination, and then the chances of having long COVID because of the exposure to the whole infection and disease process that follows after that is minimized, and it's a very strong.
If you're vaccinated, chances of getting long COVID are reduced.
Very much so. Yes.
Yeah. Richard?
I think, are we going to see a fifth wave? Yes. We're going to see something that will probably be defined as a fifth wave. I think the uncertainty is about whether we're going to see that still sticking to the same pattern that we've seen. So in another few months, which would be around April, May, maybe, that we'll see another surge with another new variant. We don't know whether that's the case, or whether we're going to see us fall into a slightly different pattern, that maybe we see smaller resurgences. And so there's a lot of uncertainty, but clearly we're going to see in the future further resurgence of infection. The key thing is whether we can, and one thing is that we don't know for sure that the next variant that comes along will also kind of be have a lower risk of severe disease like Omicron. We don't know that with any certainty. And so the priority for us is to get that level of protection up that we've seen has done us well with Omicron, but we need to get that level of protection in the community up even higher, so that even if we see a wave of infections, we see much less impact of that in terms of our hospitals and in terms of deaths.
Yeah, thank you. So we are at time, and clearly, Mary-Ann, you can see that there's still a lot more questions that are being raised by the participants. And I have to note, Mary-Ann, that a lot of the questions that are being asked, some of them are quite basic questions. And I think that there's a need to, as Kanye said, there's a need to sort of go back to the basics. There's a need to kind of hold a discussion that helps people to express the sort of basic issues. And we may not do justice to those questions. And when we engage with this sort of high level, controversial questions, when people are still wanting to go back to understand some of the basics. And Kanye is right that those basics are actually important in helping people now to engage in the sort of a little bit more complex and controversial issues that are being discussed today. So I want to wrap up, but before I do, let me just give Kanye and Richard 2 seconds each to give their final closing remarks, key messages that you'd like to share briefly. Richard?
Key message is this virus is not going away. It's with us now for the long term. We've seen what works to protect ourselves as individuals and to protect ourselves as communities. So let's come together and do more of that, strengthen that protection, and try and get back closer to that normality that we all strive for.
Thank you, Richard. Kanye?
Yes, I'd also like to echo what Richard says, and just to add that let us not fall into that false sense of complacency where we think because the virus has been with us for long, there's this thing that it's becoming endemic, that endemic means less harmful. That is not true. We know of TB, we know of malaria, things can be endemic and have very dire outcomes. So let us still remain vigilant, and at least with this, we have effective vaccines. So increase that level of protection through vaccination as much as we can.
Thank you so much. Thank you, colleagues, for your patience, for staying for so long. We really appreciate your time, your engagements, and the questions that you've raised. And I'm hoping that Mary-Ann and team will document these questions, the ones that have not been answered. Our colleagues here, our experts here will address them, and you can have access to them in some way. And hopefully, Mary-Ann, you can schedule an engagement where people can also begin to engage with some of the questions that have been raised here. So, and as I said, I think that we just need to create space for a more basic discussion now that people are actually interested and willing to listen. So thank you so much, colleagues. Wishing you all the best. If you haven't gotten a vaccine, please go get a vaccine. If you need a booster and you are 50 years and above, definitely if you're 60 years and above, please go get a booster. And then if there are any other questions, I'm sure that Marianne can assist in facilitating those answers. All the best, and we may adjourn. Thank you so much. Bye, everyone.
Bye.
Thank you.